Good morning, everyone. We'll be starting with first case for this morning session from Eartham, live demonstration. First case for today's session is 50-year-old female patient, diabetic. On routine cardiac evaluation, was found to have well-defined non-enhancing cystic lesion in posterior mediastinum along right lateral aspect of mid and lower thoracic esophagus below carina. Over to Dr. Radhika.
Thank you, Dr. Chetty.
Dr. Jay Bhatt and Dr. Patel from Ahmedabad and Dr. Jay Bhatt from Jamnagar to chair the session, please.
So, good morning, everyone. I am Dr. Radhika Chauhan, consultant gastroenterologist at Ansh Clinic, and with me, Dr. Harshal is there. So, we are going to demonstrate linear anatomy of mediastinum. In this patient, subepithelial lesion is there. So, we'll demonstrate mediastinal anatomy as well as a demonstration of SEL on linear EUS. I have.
Yes,
Can you see endosonal image?
Yes, both the images are there.
Okay. So Harshal sir is pointing a IVC. You can see the IVC there, and you can see the right hepatic vein also joining the IVC. So I am withdrawing my scope slowly. So you can see the right atria is coming into the picture. So this is the right atria where IVC is joining, and I am withdrawing my scope slowly. So you can see the right ventricle is also coming into the picture, but very small view is coming. Withdrawing again. So you can see the left atria there. Left atria. If I do anti-clockwise from the left atria, I will see the left ventricle as well as mitral wall. And if I do clockwise, I can see the aortic root there below. And I'm again withdrawing my scope. So this is a sub-carinal space. It is between the left atria. We'll freeze it.
Yeah. No, get the pulmonary artery in view.
Yeah. So you can see this is a sub-carinal space where on left side of the picture is left atria, and on right side it is a right pulmonary artery.
Yeah, I just labeled
Yeah.
it to them. This is the left atrium, and this is the
Pulmonary artery. So this is a
this becomes the
subepithelial subcarinal space, and the subepithelial lesion is started coming into the
picture.
view.
Right. Now you can just.
So with linear US, you can see whole heart, and in one patient even I have aspirated pericardial effusion because it was not amenable with a percutaneous, it was loculated. So you can see a very clear view of a subepithelial lesion, and in my opinion, it is a duplication cyst. What is your opinion, sir, on this?
It's a very homogeneous kind of very well-defined thing, and if you correlate with the CT picture, it does look like this could be a duplication cyst, mediastinal duplication, and it seems to be very close to the esophageal wall. So as you know, we have probably 3 types of mediastinal duplication. This probably fits into the esophageal one.
Yes, sir. And I could see some Brownian movement, that is Brownian movement of a liquid also. And it is in relation with the pleura, so that's why bright echo is coming on the endosono.
This is what the pleura would look like. You can see the reflection of the rays behind. So that's the air that is there in the...
Radhika, the impression of the house here is, why not it is lymph node?
Sir, you can see some Brownian movement, and this is having a well-defined wall. And
you can see some vessels also inside.
No, sir, that is because of artifact. That is
those
because
are
of
not vessels. These are not vessels. They are artifacts. When you are actually having your transducer pressing against the esophagus, you can get those kind of artifacts.
And maybe because of liquid movement.
Correct. So
liquid movement in duplication cyst giving these
those
artifacts.
Can be seen in all kinds of lesions that you see under the transducer. So these are not really vessels.
And the frequency I have kept here is a 7.5 megahertz we can increase because with increasing frequency, resolution will be better.
Resolution will be better.
So I will increase the frequency now. So now you can see.
Can you appreciate the change in the echo density of the image? It becomes a little more
Yes.
sharper. And if you see this, what Dr. Radhika is mentioning is that movement that you can see inside. Probably
So what is the origin of this lesion? Which layer?
So it is from the muscular
Sir.
layer of the esophagus,
So we'll increase again.
and that probably
Yeah.
will be able to.
Sir, this looks like a muscularis propria,
Propria.
because mucosa and
It is-
submucosa merged with the transducer, and this is the muscularis propria.
So if you see, this is the origin here. This seems to be the origin. This is the outer layer of the esophagus, and this is what is continuing around here. So looks to be the outer muscle layer of the esophagus.
And further in mediastinum,
And in that question whether this is a lymph node or not, a lymph node would be a little more irregular. The shape would not be so.
and that heterogeneity,
and
this one,
heterogeneity
yeah.
would not be there. So then,
No,
and
the
of course,
conglomerated lymph node can give rise to the same picture.
no, conglomerate. In fact, it is very easy to make out because there will be a lot of septae around. Because conglomerated lymph nodes is 3 or 4 lymph nodes coming together, so you can easily make it. This is a single homogeneous structure. You can see there is no septation.
And
there is
the
nothing.
the picture is very clear. You can
Yes.
see all the wall layer
Yes,
here.
you can see the esophageal wall continuing into the cyst. That is very
Yes,
important.
gut wall signature.
Yeah,
Yes.
this
So that
one.
is very, very important. So it's very nicely demonstrated by Radhika, because this is some probably how you would be sure that you are dealing with a esophageal lesion rather than so in a lymph node, you could actually see a plane between the esophagus muscle and the wall of the lymph node. So that probably how you differentiate and helps you to differentiate. Again, it is very important because this kind of a duplication cyst, you don't want to land up puncturing this cyst. So we need to be doubly sure that we are dealing with a duplication cyst rather than a.
Yeah, if you puncture,
Yeah.
very high chances
Yeah, we
of
could
infection.
land up getting that cyst getting infected, and then we would be probably rushed into treating her.
So from here, if I do more clockwise, I will see the descending aorta.
Yeah.
Okay, so on linear, the descending aorta will, yeah. And you can see the mirror image of a descending aorta because the reflection from the pleura. And if I withdraw again, my aorta, the shape will change, arch of the aorta. And if I do more clockwise, I can see the aorto-pulmonary window.
So again,
ADP assigned, no sir?
correct, yes.
Yeah.
So this is your aorto-pulmonary window. The aorto-pulmonary window and the sub-carinal space are the two important places where you will get lymph node.
So this is station 4L and 5 and 6 is not amenable. Yeah,
You
that is
are not able to reach that.
okay. So anything you want from us in mediastinum to show?
So
Chairperson?
It was very nicely demonstrated, Radhika.
Thank you, sir.
yes.
We'll start with the next case.
Yeah.
Okay. Thank you. Thank you, Cheti.
Thank you.
Thank you, everyone.
Thank you, madam.